Our topic now brings us to subacute and chronic headache. Up until now, we've looked at acute headache. We've closed a chapter on that. Let's get into chronic and subacute. Migraine, pseudotumor cerebri, mass lesion, tumor abscesses, tension-type headache, chronic daily headache, trigeminal neuralgia. All of these extremely common in our society. You need to make sure that you're quite well versed with how to first identify it, diagnose it, and management. You're good to go. We'll first take a look at migraines. Unilateral throbbing. Throbbing. Duck. I feel like my head is throbbing, pulsating. Associated nausea and vomiting. Typically, unfortunately, begins in childhood, adolescence, young patient. 90% of your patients will be less than 40 years of age. Much more common in females, migraines. What about cluster? Much more common in males, young. Patients generally want to still lie in the dark because if they are exposed to light, it bothers them. Be careful. Differential, obviously here, meningitis, migraine headache. Classification. Classic, you have the aura. Common, without the aura. Migraine variants. Maybe there's involvement of the eye, so ophthalmic or retinal. Menstrual, hemiplegic, and basilar. These are variants. Common, without aura. Classic, with aura. All are based on, sterile inflammation of blood vessels. Sterile, not infective. And they're near the meninges, with activation of the trigeminal nerve, perhaps. This may seem to be the trigger. Not exactly sure, but that is a theory that you want to be familiar with. Remember, this is sterile inflammation. Classic. With or without aura, please? Good. With aura. 50 to 20% of migraines are these, associated with preceding neurologic symptom. That's your aura. You have a predisposition that, oh my goodness, I'm about to have a headache, which is stereotype for that patient. That sucks to know that it's coming and there might be nothing you can do about it. Progresses over 30, 60 minutes. That's a lot longer than what? Cluster. A cluster headache, when was that? An acute headache. Where are we now? Subacute, chronic. Nausea. Doc, I don't feel well. Feel like I'm going to pass out. Vomiting is not uncommon. Associated with photophobia, phonophobia. So loud sounds and lights are difficult. So if you're, and I'm so sorry, if you're a migraine sufferer, I'm probably one of the triggers for much of your migraine. And for that, I apologize, but there's nothing we can do about it at this point. So I feel you. So thank you for being here. Next, the headaches persist for 4 to 72 hours without treatment, although can often be terminated by sleep, if possible. Obviously, easier said than done. Classic migraine. Common, without aura. Similar to classic, without preceding aura of neurologic dysfunction. More likely to be bilateral than classic, and often coexist in patients with classic. So just because you have one doesn't mean that you're not going to have the other. There's always going to be an overlap. But if you're taking an exam or whatever, they will be very clear about whether that aura is present or not. Management of your migraine. Abortive therapy, triptans, argotamine, and caffeine, perhaps. NSAIDs, IV steroids, valproate, IV narcotics. Triptans are a big thing here. Preventive. Avoid the triggers, such as light, maybe the sounds. Treat attacks early if possible. You won't have that aura all the time, right? And please make sure that you avoid that analgesics, which the patient for sure is going to be thinking about using, if not abusing, should be properly managed. Beta blockers, tricyclics, anti-epileptics even, and calcium channel blockers are all preventive therapies for your migraines. Summary of migraine. Female, age young, most of your patients, 90% less than 40. Preventive, as we said, avoid the triggers, your medications that we talked about earlier with calcium channel blockers. Signs and symptoms, unilateral throbbing, nausea, photophobia. But as we said earlier, it's common. It could be bilateral. Differential, we'll talk about tension type, sinusitis. Earlier we talked about temporal arteritis with acute and mass lesion. HNP for sure, image to make sure that you rule out other possible underlying issues. The tryptin can cause chest pain and flushing in such patients. Look for this. And ergotamines that we talked about, prolonged use can cause gangrene. Be careful with ergotamine, may result in gangrene, if that helps you.